Okay, we have a few questions. First question I can't answer, but maybe somebody, I don't know if you guys can answer. Somebody asked what the new PET scan in Grand Rapids is. Do we know? Unfortunately, Shrey had to leave. Did anybody?
I think he was talking about the already opened the gallium-68. They didn't have it before.
Oh, the gallium. Okay.
Yeah.
All right. So the answer to that question is the gallium-68 scan. Okay. The next question is, would a short-acting somatostatin analog help with cramping and fatigue? Because the person asking the question feels that that happens after getting lanreotide.
So lanreotide has been studied, and there's some data where when we inject lanreotide, we study the drug levels over next several days and weeks. And one of the interesting phenomena which is very unique to lanreotide is that there is a sudden spike in the first couple of days. And that's when most patients feel either have a little bit worsening of the symptoms or diarrhea. It is sort of counterintuitive, but this is explained by that little surge or spike in the first day or so. I don't think that having short acting would alleviate those symptoms, okay? But if those symptoms are very bothersome, then the only other alternative would be to try to switch to other formulation, which is Sandostatin. Fortunately, this is not a big issue in 99% of my patients, but those 1 or 2 patients who have these sort of symptoms early in the course, it's because of the way the drugs kind of suddenly release and the pharmacokinetics of it. So the fatigue and the other aspect of syndrome, which might be happening because of that, it might actually get worse that's my gut feeling. The good thing about short acting is it's out of your system in minutes, right? So you can try it. At worst, if it makes it worse, then we know our answer. But from mechanism-wise, I don't think it'll make it better. In fact, it might make it worse. So if you're not tolerating lanreotide well, you have another product that you can try.
Well, while we're talking about lanreotide, somebody wants to know if it can be given at home and covered by insurance.
You want to take that?
Yeah.
So I think when COVID started, we had these questions a lot from our patients. And the company did, working with us, and build some sort of home programs that some of the patients, the insurance approved it, and they took it at home. I don't know why, but when COVID started, a lot of patient insurance declined treating my patient in the infusion center. I don't know why. They say it needs to be either in office setting or at home. So yes, the medication can be taken at home, but I think that depends on your insurance.
I have a small, very interesting comment. So we have drug regulators called FDA who approves the drug in the US. In Europe, it's EUA, right? So they have approval for home and self-administration in landed in Europe. So if you were in Europe, patients, it's very routine for patients to give it to themselves. In FDA, in the US, the FDA did not grant that approval. So here, only a healthcare provider can inject it. Now, I have some patients who have family members who are either nurse or a healthcare provider, so they can technically give it, but then insurance also has to approve it. So there are certain hoops, unfortunately. I wish they can, somebody can lobby for, but it happens routinely in Europe. It's just the US, the way our healthcare system is structured. It has to be given by a healthcare provider. And most of the time, it's usually given in either the clinics or the centers, unfortunately.
Yeah, and one other comment, making sure that doesn't cover at-home programs is Medicaid.
But sometimes the insurance will send a nurse to your home and she will give it to you, but don't try to give it yourself because you don't want to go deep, intramuscular or something, so take care of that.
All right, so Dr. Bushnell, as a nuclear medicine radiologist, I have more of a mainstream radiology question, and that is it pretty obvious if there's a cyst or if it's a neuroendocrine tumor on the ovary on a scan, any scan?
Yeah, the easy answer to that is yes. It's pretty easy to distinguish with CT, ultrasound, PET, for the most part, whether or not we're dealing with tumor or cyst.
Yeah, because cysts tend to look, like on a CAT scan, they're dark, and a neuroendocrine tumor is going to enhance. It's going to look kind of gray or whitish gray. And on an ultrasound, it's really obvious if something's a cyst because it has water density as opposed to being solid. And then, of course, you get a DOTA PET, that'll just be pretty obvious, too. Okay, I guess this is a question for Aman. If you, I'm not sure if I understand the question, but it is, if you're treated to 100% in theory antigenesis, I think it means, tumor death, I guess, how long will it take the existing tumors to die? Or alternatively, what's the life cycle of the tumor? I'm not sure if the question is what it'll look like on scan or how long till it disappears or...
So, like Marianne mentioned at the very beginning, every patient is different. It's like zebra stripes. So the biology of every neuroendocrine tumor patient is very different. For example, grade 3 well-differentiated neuroendocrine tumor is a very fast-growing, rapidly dividing tumor cells comparatively to a grade 1 well-differentiated NET, which is very, very, very different than poorly differentiated neuroendocrine carcinoma, which are small cell. For example, some small cell carcinomas can double in 14 days. So completely different biology. So how fast or how sensitive the tumor cells are to a particular therapy like chemotherapy or radiation also depends on these factors. Usually the dictum is the faster the replication, they're more chemosensitive and radiosensitive tumors, so they die fast as well, and you would see these particular changes on scans sooner. As compared to more slow-growing indolent cancers like low-grade or typical carcinoids, they're not very chemosensitive. They're also not very radiosensitive, the traditional radiation, the external beam radiation. So you don't really see a lot of change. So if I have a patient, lung net patient, who I recommended SBRT or a focal radiation, I'm not going to get a CT scan in a month or 2 months and expect the tumor shrinkage, because you will see that it'll take much longer for a lower grade tumor. So if I understand the question correctly, there's no the specific time to expect. It depends on individual tumor growth rate, individual tumor biology, which type of tumor we are dealing with, and also differential sensitivity to the treatment, because every drug works differently. For example, CAPTEM can be very, very sensitive in pancreatic neuroendocrine tumor, as compared to somatostatin analog, which does not typically kill the tumors. It is cytostatic, slows them down. So it also depends which treatment response we're looking at.
All right, Amar, I have a lanreotide question for you. And that is that somebody said that once they started getting lanreotide shots, they started experiencing fatigue, cramps, a slow heart rate, and a higher blood pressure. So are those common side effects? And then part two is, what do you do with lanreotide when you're getting PRRT?
So the first question, the most common side effect in the ClearNet trial and the PROMET trial, it does slow the heart rate, cause bradycardia, but does not reach a significant clinical bradycardia. It can elevate the blood pressure. That's definitely happen, and we can see it sometimes. Usually the cramping and increased diarrhea can happen in the first couple of shots. I experienced that with my patient the first 2 or 3 months, and then everything gets much better after that. And in these days, I only give them Gas-X or give them Imodium, something to alleviate these symptoms. The second question, somatostatin analog rule with PRRT. So the NETTER-1 trial, when they add the octreotide plus the PRRT, the main idea was not to improve progression-free survival by adding octreotide. It's to improve the symptoms, the patient who have clinical symptoms. So the question will come after that. If the patient progresses on somatostatin analog in the first-line setting and does not have clinical symptoms, no hormone overproduction, do you need to continue somatostatin analog in the PRRT in the second-line setting for progression-free survival benefit, not for hormone secretion? We did this survey at the ECOG, and it came back 50-50. So 50% of the oncology was saying, I will, and 50% will say, I don't think there is any data about it. There is only one retrospective study that they did add somatostatin analog plus the PRRT, but was retrospective, and they did double the progression-free survival from 23 to almost 44 months. This was retrospective, had a lot of selection bias. So we don't know, we don't have a prospective trial, but if your patient does have symptoms of hormonal secretion, I will definitely continue lanreotide or sandostatin. If they do not, I think it will be a discussion between me and my patients to see what is the risk versus benefits.
Yeah, it's a hot topic for debate in our field, whether to continue somatostatin analog, be it sandostatin or lanreotide, during and after PRT in non-functional patients, so those without any syndrome. I'm in sort of that other 50% camp who continue, especially after that German study came out and suggesting that there could be some potential benefit. But it's retrospective, take it with a grain of salt. My rationale is, as long as patient, it's not a overt financial burden, logistical burden, and they're okay with continuing the shots, they don't mind getting a shot. The thing is, even after PRT, PRT is not curative. We are not killing or eliminating all cancer clones. So, and PRT is very limited dose, 4 doses, right? So there's a big time gap after PRT that we are not treating patients on anything. So I feel that somatostatin analog would potentially have some added potential. Has to be proven, though. But at this point in time, it's either way is okay. I tend to lean towards continuing SSAs during and post-PRT. During PRT, the nuance is you don't want to be giving it immediately before the PRT because it is competing for the same targets. Sandostatin lanreotide attaches to somatostatin receptors. So does the Lutathera. So you want to keep the somatostatin receptors as free as possible. Now, of course, in real life, it's not. There will be some degree of drug in your system, but the way it was done in Netter, one study is that you need to at least have no somatostatin analog 6 weeks prior to Lutathera. So you have to give it intermittently, and then you can get back on monthly after.
Well, I have a PRT question here for Dr. Bushnell. My latest scan showed I had minimal progression, but my physicians are now talking about giving me Lutathera. But my question to you is, should I hold out for these alpha agents, and when do you think they might be more widely available?
Well, not knowing the specifics, other specifics, obviously depends what, I'd certainly rely on your local clinicians and in your decision process together to decide in terms of whether you need to sort of move forward more quickly as opposed to whether maybe you could hold off. It might be possible for you to think about enrolling in a clinical trial. As we talked a little bit about the Raise Bio trial, which may move into phase 3, just as a ballpark guess, after about 18 months. I think, is that too optimistic? That might be too optimistic. And then there are the phase 1 trials and AlphaMedix. But AlphaMedix is the trial, of course, is with PRT naive patients. So, yeah, really that's a question well discussed with your local folks and see what you come up with. Sorry, I couldn't be more definitive. Do you want to say?
Just a small caution. So clinical trial, let's suppose a clinical trial is opening up. So for example, we are very, very close in opening Raise Bio trial. But that does not guarantee somebody gets the drug because there are a lot of factors. When a phase 1 trial opens up, they're probably going to treat 3 patients, whole country, right? And then they would see how those 3 patients did. So there's what's called dose-limited toxicity window. And when all 3 patients did fine, or at least majority did fine, then they open next 3 spots. So it's a very slow, tedious process. In the meantime, if your cancer is growing and progressing, we don't want to lose a lot of that time. So there's a lot of uncertainty in the clinical trials, right? So even if the trial opens at a particular spot, doesn't guarantee that you will get in. So you have to factor that in. At the same time, the alpha PRT trial, there are now, fortunately, a lot of options, both in frontline PRT setting and refractory PRT setting. So I don't think you will miss out if you, let's suppose, proceed to go with standard PRT. The good thing about standard PRT is fully vetted. It's studied in hundreds of patients. the Erasmus data, literally hundreds of patients, and then NETR-1 study, and FDA has reviewed it, and we know that this works. So the best data out there to date is still the standard PRRT, and it works. The alpha PRRT is still in a clinical trial. The clinical trial 5 years later might show that it is the game changer and we hit the home run. But there's also a chance that it might turn out to be negative or more toxic or more MDS rates. So we don't know. There's a big unknown. So anytime you have standard treatment option, which is fully vetted, you should definitely consider that strongly. At the same time, talk to your local oncologist or seek a second opinion in the NET center to review your clinical trial option. And if the trial sounds like a good option for you, or you can wait, or you have the option to get in, then you can make that informed decision. So it's not an easy decision, oh, alpha is the best, or beta is the best, or drug X, Z, Y, because every patient is very unique. You have to look into a lot of other variables.
Just a quick point in that, also ask your physician how long it takes you for the tumor to grow, as Aman was saying. And I want to ask him, how difficult to get your patient with a grade 3 well differentiated if they have a positive scan to get insurance approved for PRRT?
Yeah, and you know, this is a very, very good question, because I recently had a similar scenario where it's a very fast-growing tumor, and the tumor had a lot of somatostatin receptors. The gallium scan was lighting up like a Christmas tree, and I wanted to do PRRT, but unfortunately we had the PRRT kind of slow down, etc. So sometimes we have to start chemotherapy because of that, because typically it might take at least 2 weeks to get FDA, the insurance approval, and to get things set up, right? This is not chemotherapy I can prescribe today, and we can try to get it in 2 days to patients. So we have to factor in, is the patient in visceral crisis? Is the tumor growing so fast that I'll lose that opportunity to treat the patient? Also, PRRT takes time to work. The way the radiation works, the radiobiology, the mechanism of action, the radiation-based DNA damage happen over days to weeks, right? So while the chemotherapy effect starts right away. So you have to make that decision based on, is the patient symptomatic, how the organ functions are looking like, and the availability of drug. The Lutathera supply chain issue has now been resolved, so we are back on track, but this could be very limiting. So I'm always very nervous in grade 3 well-deficient NET patient about access to drug in a timely fashion. And there are 2 big phase 3 trials going on right now, the NETR-2 and the COMPOSE clinical trial. So I try my best to get these patients on these very two important trials, because if they finish and they are positive, that would expand the PRRT as an option for higher grade tumors as well. So we really want to see these trials to fruition. But at the same time, the primary goal for all the doctors is patient first. So if the patient really needs treatment and we don't have PRRT right now in a timely manner, we start with the chemotherapy.
All right, thanks. All right, Dr. Mohammed, this one's for you. What is your current recommendation for a non-symptomatic patient with a neuroendocrine tumor, say a carcinoid tumor, who's going to have colonoscopy, who's normally on lanreotide? I think it's a question about prophylaxis.
Yeah, so the idea of bolus octreotide or octreotide drip, I think Nemitz did a great job for specific guidelines. I think Enets did the same as well. Usually if the patient have an major invasive surgery, I definitely start this patient on octreotide drip or high-dose octreotide, sometimes 12 hours before procedures, during the procedure, and can be at least 48 hours even after they finish. Colonoscopy and the minor procedures, I don't think we have a good data about it, and I don't think there is a strong recommendation to start them in high-dose octreotide or octreotide drip or anything like that. So usually if they are already on samdostatin, because not hormonal secretions, they have the good receptor, and then do it more for progression-free survival, I will just continue the monthly octreotide or lanreotide, but I will not add specifically octreotide drip or high-dose octreotide for a colonoscopy or EGD.
Yeah, Dr. Pommier did a nice study where he actually put invasive catheters into patients having surgery for neuroendocrine tumors, carcinoids with liver metastases, and they tried to correlate drops in blood pressure, which goes along with carcinoid crisis, and levels of hormones, and then also looking at the efficacy of octreotide boluses to reduce that or the episodes, and found really no difference. And his group has actually abandoned using octreotide during their cases. I still run it at 100 mics an hour, but I think he studied it very well. And so for a minor procedure, I think maybe it's just important to let people know you have a carcinoid, and if you drop your blood pressure, then maybe they can give you some octreotide, but maybe not to do it prophylactically. Well, Dr. Bushnell, what should a patient expect radiographically after getting PRRT? Somebody said that they got PRRT and they expected it, your slide showed that the tumor is being killed and so forth, but the lesions were still there on CT scan.
Yeah, one of the very first, when we were using yttrium, we were doing CT scans after the first and second cycles, and in the first couple of patients, we saw actually the CT scan showing a bigger area of diminished attenuation. It just looked darker, and we began to realize what we're seeing is just swelling as a consequence of the radiation. Now, we've recognized over the years that it can take months, and I think the comment about it takes several weeks to get the radiation energy into the tumor, and then the damage continues, and it's a slow death for the tumor cells. And the CT scan, because much of what we see on the CT scan is sort of just the structure of the tumor. It's not, of course, this is something Dr. Howe would know much better, but it's not just all tumor cells. There's a skeleton of sorts, and the tumor cells can die off and go away, but the CT scan continues to show sort of the backbone of the tumor for months and months. And there's certainly reported cases, and we've had a couple, where it may be a year after the completion of the Lutathera before the CT shows the shrinkage of the abnormality, particularly talking liver, but lymph node as well.
But in NETTER-1, didn't it just show that there was a partial response rate of 28%? I mean, a lot of them don't change at all, right?
It's actually, they
Yeah.
reported 18, but now the newer FDA label is 14%. So they probably cleaned up the data. So what that means is that only if I treat 100 patients with PRRT, Lutathera, only 14 patients would show shrinkage to an extent where we call them partial response, so 30% shrinkage or greater. Majority of patients, it's cytostatic. So it's not, it's. Please don't be sad to hear those numbers. To put things in perspective, Sandostatin and Lanreotide, the response rate is 5%, right? So we made quite a bit of progress from there. Afinitor, 7 to 8%. So we at least are in now double digits. There is room to improvement, but a lot of time what we really need is disease stabilization. And Lutathera works really well for that, right? So close to 29, 30 months versus, I think, it was 8 months or NETTER-1.
Was the long acting?
Yes, control group,
Yeah,
right?
I think it was 8, something like that.
8 months versus 30 months, that's a big difference. But yes, we are not there at the point where it shrinks tumors in all the patients. So to expect the tumors to disappear, it happens rarely. And we're trying to do that in our novel clinical trials to increase that cytoreductive capacity. But majority of patients, the tumors would still be there. They might not be active. They might be dormant. But don't worry if you don't see tumor shrinkage. That's actually the common thing to happen. Very few patients show those beautiful scans, the complete response. Every time we see a complete response, trust me, we get equally excited just like our patients. So that's, but we are trying to strive to do that in most of our patients, but that's still not a common occurrence as of now.
And you usually wait 12 weeks after the last treatment, right, to get another restaging anatomical scan?
Yes. we try to avoid scanning too soon because of the same phenomena. Early in the process after PRRT, there is a lot of cell death, necrosis, and edema. So the tumor actually looks a little bit bigger, and the patient usually worry, hey doc, you said my tumor is going to shrink, but actually looking bigger. They're actually dying. We call them pseudo-progression. It's a real phenomenon. That's why many times nuclear medicine doctors would not even like to do an early scan. However, we are doing a lot of clinical trials, so we are mandated to do scans every 2 months. So we are seeing these trends that early on in the course that there is definitive either stability or worsening of the disease. That's actually not really worsening. It's a pseudo or false progression. But if you give enough time, with time, this would shrink to some degree, okay? And it is also well known from European data set that tumors after PRT can continue to shrink even 2 years later, okay? So that's how you have to be patient. As long as, so if it's a standard of care patient, I try to do my first scan usually after the 3rd cycle just to kind of get some sort of, okay, things are not going, but you can actually do all 4 cycles and then wait a month, month and a half, 2 months and do that scan, and that's good enough time. We are like literally 8 months into the treatment by then, and we should start seeing either some shrinkage or stability for sure, okay?
Well, those are all the questions, unless somebody wants to come forward and ask another one. Come on up.
It's a once-in-a-lifetime opportunity to ask question of world-famous surgeon. Yeah.
I don't know. Am I on? Is it working now? It's
Yeah.
working. Yeah, it's working. Oh, good. All right, I'm on. So I want to know, we learned a lot about all the tools in your toolbox and a lot of treatments and a lot of things. Are there any of them that don't have fatigue as a side effect?
I think this is the most common toxicity in all the cancer treatments, you know, whether chemotherapy, targeted therapy. I don't think that the somatostatin analogs, the fatigue is quite well compared to the chemotherapy, to be honest with you, or even the immunotherapy. But that's one of the most common. I think if you read all the clinical trials, the first thing you'll find in the table of toxicity is fatigue. So that's something I think very, very common.
Well, your body's going through a lot, and you're healing a lot, and you have toxins you have to get rid of. It all spells fatigue, you know, right?
One of the things I think we've seen with the Lutathera, maybe a little advantage, is that fatigue almost always melts away after about 7 to 10 days. I mean, it does hit frequently, but then it's usually gone. So it's not long lasting. I don't know about some of the other agents. Maybe it kind of goes for a while.
Yeah, I mean, so fatigue is part of not just the treatment, but also part of the disease itself, right? So many cancers, cancer is a state of cachexia, breakdown, right? So our body is, the cancer cells are creating certain chemicals called cytokines, causing you to lose weight, causing you to have low energy, like fatigue, and all those things. So to begin with, the cancer itself kind of gives you all those constitutional symptoms. Then on top of that, we have to fight the cancer with pretty tough drugs, right? We would not give these drugs to anybody without the diagnosis of cancer or tumor. So unfortunately, that's sort of a collateral damage. In my experience, somatostatin analogs are by far the easiest one in terms of but the drugs like radiation-based drugs like Lutathera or other form of radiation or chemotherapy, which can affect bone marrow. Bone marrow is the factories where you make blood cells, red blood cells, platelets, white blood cells. So red blood cells are the ones which carry oxygen. So if you become anemic, you start developing fatigue, right? If your blood counts are coming down too low, cytopenias, then talk to your doctor. You could have been symptomatic anemia. One common factor, especially in males, cancer patients in general, is low testosterone level. So if there is significant fatigue, you'd be surprised just by fixing the testosterone level that you can actually help with the fatigue symptoms. The other thing that can happen in cancer patient or any stressful state is hypothyroidism. So low thyroid level can also present as fatigue. So these are some of the things that we can help with: nutritional deficiencies, anemia, low thyroid levels, testosterone deficiencies. But if all of these are okay and you're still having considerable amount of fatigue to a point where you're not able to function, you don't have quality of life, that means the drug got to go and we got to try a different. Because at the end of the day, the two big goal for a cancer doctor is that our patient should live longer and the patient should have the best possible quality of life. So if you are not able to provide those two goals, it's not a viable goal for me to prolong the patient's life, but they're just sleeping all day or they're in the recliner all day. That's not our end goal.
I think that's an important point in people on somatostatin analogs, is that it does inhibit thyroid function. So it's important to have your thyroid levels checked, because it's a common side effect of just things that we think are benign, like lanreotide or sandostatin LAR.
I have a question related to PRRT, and you mentioned counts dropping and stuff. And then you mentioned starting a patient maybe on chemo right before PRRT, and that affects your counts too. So at what count levels, like your WBCs, your platelets, your ANC, does a red flag go up for you?
So we have treated, since FDA approval, we have treated well over 200 patients with standard of care Lutathera. So fortunately, blood counts being low has not turned out to be a big problem that we expected. One of the blood counts that does give us some trouble is platelet count. So that definitely dictates how much PRT I'll give. So I at least want to see 100,000 or higher to be able to give full dose. So if the platelet counts are 100,000, below 100,000, then I usually give them half a dose or less. If they're 40,000 to begin with, they might not even be a good candidate for PRT period. As far as the red blood count or anemia, that usually is not a big problem in my experience. For chemotherapy, and chemotherapy in our area of oncology is what we mean is CAPE-TEM, because we often don't use other IV chemotherapy. For that, usually I don't want to see hemoglobin below 7. That's usually a safe limit for me. If somebody's having anemia 5 or 6, I really need to transfuse them and figure out what's going on and then start the chemo. Same thing true for the platelet counts. I'm a little bit more generous in terms of platelet count for chemotherapy, so I can give chemotherapy to somebody with platelet count 60, 70,000. So you have to factor in risk benefit, but the dose might have to be optimized of the chemotherapy. So many times I would drop down the dose of temozolomide based on how low the blood counts are. White blood counts, there are different types of white blood counts. The one which is really important for all of us are called neutrophils. They are the fighter cells against the bacterial infections. So we really want absolute neutrophil count over 1,000. Anytime it's less than 1,000, very high risk for developing infection and serious infectious complications. But again, these are for chemotherapy. For PRRT, usually this is not an issue. Platelet can be an issue, so we look for those very closely and I optimize. Dr. Bushnell, is that what you guys also do?
Well, we're maybe a little bit more. So we dose modify. So you give 200 millicuries as that first cycle, for example. At some point after that cycle or the next one, if the platelet count goes below 75,000, then we wait until it comes back up before dosing. And but as long as it's above 75,000, we typically continue the same 200 millicurie. Below 75, we dose modify. Below 50, I don't think we've proceeded.
Okay, thank you very much.
Okay, another question. Get ready, guys.
I have two questions. One is, we're going to have a wedding for a daughter here shortly, a couple months. And my husband has had Whipple with a lot of complications and liver infections and things like that. And someone suggested Evusheld. Can anybody address that?
It's the monoclonal antibody for COVID.
Yep. He's already had 3 regular doses of Moderna and 1 booster.
So we are routinely giving Evishield in our clinic, anybody who is immunocompromised. So these are a lot of my high-grade neuroendocrine cancer patients on chemotherapy. I am not giving typically for carcinoid patients who are not on immunosuppressants, but it is a pretty low-risk medication and can be considered, especially in your case, if the patients already have sort of some degree of sort of immune compromised status because of chronic illness, and it's a pretty low risk. You should consider. We are routinely giving it to a lot of patients actually.
They talk about carcinoid.
From Evishield, I'm not aware of. So it's a monoclonal antibody, and I'm personally not aware of it triggering carcinoid crisis. Certain drugs like epinephrine, which cause vasoconstriction, can make your tumors kind of. It'll be. Dr. Howe, have you heard of Evishield and carcinoid crisis? I've personally not heard of it.
Heart attacks, I think.
I think you also mentioned about WEPL and the risk of COVID. So I think doing WEPL will put you at risk of encapsulated bacteria infection, and you have to have specific vaccines. I don't think there's a very strong data for putting you at risk for having COVID more than the general population. And he can correct me.
Well, yeah, in a Whipple, you don't remove the spleen, so I think you were talking about
His
a
spleen-
splenectomy patient. So
His
they,
spleen is gone.
from a Whipple?
He had a total pancreatectomy and spleen.
Oh, splenectomy, yeah.
What, ask you guys, what about Paxlovid for prophylaxis or initial treatment in people that are a little higher risk?
Yes, so we are not doing Paxlovid as a prophylaxis. We are definitely doing it for treatment early on. Again, I'm not an infectious disease doctor. A lot of time I would curbside my infectious disease colleagues in challenging cases, but we do have a protocol for Evishield for sure. Where we are routinely screening patients, anybody on chemotherapy, we're getting it to the patient, lower their risk. Now, these kind of scenarios where patients not on an immunosuppressive regimen, I'm not personally aware of, so please talk to your doctor about risk-benefit. No drug is without side effects, right? So there are side effects to even vaccines. If you look at the reported side effects, people can react to vaccine, can develop issues, myocarditis and stuff. So there are always pros and cons, but if the pros outweighs the risk or potential risk, then you might want to consider. But as a drug class, we've been giving it to a lot of our cancer patients.
And no one's had any minor
No.
heart attacks or anything?
No, not that I can join the dots, and this goes much beyond NETs. We are doing this for all cancer patients at cancer center. So again, please talk to your doctor, but we've had a good experience with Evishield.
How often would they get that? Because it's a pre-exposure kind of drug.
So you cannot get it if you have a documented infection, I think within 90 days, if I'm not right. So if you've already had COVID, you won't qualify. But if you never had COVID or didn't have recent COVID, then you can get it, I think, and it covers you for, it should cover you for
6 months?
6 months, yeah.
But what about other infections? Because he did have other infections.
It shouldn't really. So the way the monoclonal antibody is to neutralize the COVID virus, so it shouldn't really had either a good or a negative effect on other things happening. And it shouldn't really protect from any bacterial infection, right? So that's a completely different situation. I can see that there could be potential anatomic issue, which is predisposing your husband to get, bacterial translocation from the GI tract, and there's no spleen, so that's also, spleen plays a big role in, building an immune system, right? So that's another, those are very typical capsulated organisms, so you need to have vaccines for pneumococcal and influenza and all those things, right?
We've been working on the list from Iowa. to get
Oh,
all-
okay, good.
All the vaccines
good.
he's supposed to have, we've been working
Good,
on it.
good. But there's no hard indication that you have to get Evishield, but I think it's a low-risk drug in my mind, and we've been doing it in a lot of our chemo patients for sure.
So maybe wait until, if there's an exposure that we're aware of.
Yeah, I mean, one thing I would tell you that there is evidence now to suggest that cancer patients who have COVID have worse outcome,
Right.
right? So if two people get COVID, the patient who has chronic illness or cancer is going to have higher odds of having a worse outcome.
Right.
So our goal should be to maybe prevent the illness to begin with. So I guess this is where you're coming in from. But unfortunately, I don't have data to support or tell you that Evishield has worked in patients who are not on immunosuppressed drug, right? But it makes sense. It makes sense that, okay, maybe it will help. And if it helps to prevent a very significant infection, then the chance or odds of having poor outcome would also be lower, because we do know cancer patients with COVID have worse outcome as compared to general population.
So especially you consider it for chemotherapy, everolimus, or Lutathera if they got myelosuppression.
Yes, Lutathera in particular, because I've been tracking the blood counts on all these Lutathera trials, it causes lymphocytopenia, which lingers on. So lymphocytes are one of the blood cells which helps us build immunity against viral infection and parasites. So Lutathera patients for sure can get Evishield. In fact, we are giving Evishield to them.
Okay, I got one more, and this is Histograpsy for liver. I heard about, I don't know much about it, but
That's a perfect way to finish, Dr. Howe. That's your question.
I don't know what Histograpsy is. I've never heard of it, so I can't help you. Do you guys know what it is? Histograpsy?
So I've heard of lithotripsy, which is breaking down a kidney stone with help of sound waves. I bet it is some sort of similar phenomena. It's a technique using some sort of sound waves to destroy a tissue, like a cryo freeze it. I think that's what it is, but we don't do it at Kentucky. So unfortunately, I can't guide you further.
Yeah, I've never heard of it, so I doubt it's a popular technique or it's been proven, so I'd stay away from it for now. Did you have a question, ma'am?
Hi, thank you. I am relatively new to this, and I've heard about carcinoid crisis. I was wondering, how do you know? Like, what are the factors? What brings it on? And what should I be looking out for? Triggers, that kind of thing? I figure other people might want to know, too.
The 5 E's.
Oh, are those the triggers for carcinoid?
Yeah,
Oh,
carcinoid crisis. Yeah.
okay. Yes, carcinoid crisis.
Yeah, so why don't you guys tell them what the 5 E's are? Let's see if you've listened.
Gosh.
Eating,
I
exercise.
can help you. Eat, exercise,
Ethanol,
ethanol.
And emotion.
emotions, stress.
Okay, and I've heard that can come on during surgery. Should you just warn your surgeon
Yes.
ahead of time?
Very important that your practice is aware. Not only surgeon, you're going for a dental implant, anything where your body is going to be manipulated. You let them know about your history of neuroendocrine tumor, functional neuroendocrine tumor, carcinoid syndrome. That should raise the red flags. They might not necessarily do anything different, but they will be at least aware in case during a procedure blood pressure drops, something happens, or at least they will be aware that not to give certain medications which are contraindicated, like epinephrine. So it's very, very important. And anytime you go for a major procedure, anyways, anesthesiologist takes a very detailed history, which this is a part of that. But I would definitely advise, be your own advocate, definitely tell them, hey, I'm a carcinoid syndrome patient, just be aware, what would be the symptoms? You probably wouldn't know during the procedure, but your anesthesiologist would have to deal with it. It will be low blood pressure, bradycardia, all those things, which we don't want to see.
Okay. Thank you so much.
Yeah, and just be aware that not everybody knows about this. This is the whole purpose of this conference is to hear about this rare tumor, and not every general surgeon who might operate on you knows that, and not every anesthesiologist does either. So it's okay to tell them, I have a neuroendocrine tumor. My doctor said you should be aware of the possibility of carcinoid crisis. You just say those couple words, and they'll be paying attention.
Can I say something?
Yeah.
I'm gonna say it into the punch.
No, Marianne, I'm sorry.
I'm going to talk. Okay, I'm giving the patient's perspective. Okay, first of all, you're a newer patient? Okay.
Yes.
So this is one of the things that is on the This is one of the things I talk about on the internet. Not everybody that has a neuroendocrine tumor will get a carcinoid crisis, okay? Usually it's when you have a lot of tumor load in your liver, okay? Unfortunately, I'm one of those strange ones that had carcinoid syndrome really, really bad, but they could never find the tumors in my liver. So it doesn't always happen. But a lot of people on the internet, especially on those Facebook pages, will say, oh, you have to worry about carcinoid crisis. I have to worry about it. Not everybody gets carcinoid syndrome. And there's a difference between dumping and carcinoid syndrome. And maybe Dr. Chouhan would, or one of the doctors would speak about that, because a lot of people are under the impression that when they're going to the bathroom a lot, that it's carcinoid syndrome or carcinoid crisis. It's not. Believe me, when you have a carcinoid crisis, they'll know. They'll know, because I have had it. I've had it twice on the table, and one time, literally, the nurse had to run out to the hallway to get Robert to give him the octreotide to bring me back. So it does happen, but I don't want you panicking when you go online and you see that, because what happens is a lot of people get anxiety, and the more anxiety that you get, the more you're producing hormones that are causing it. So you have to, bring your emotions in and know that, yes, it can happen, but it doesn't happen every day. And that sometimes the diarrhea is just carcinoid syndrome, but not a carcinoid crisis. Because I get calls all the time, oh my God, I'm having a carcinoid crisis. And I'm like, well, how's your blood pressure? And they're like, oh, it's fine. I just went to the bathroom 10 times. Well, that's not the same. So maybe Dr. Chouhan, can you explain the difference?
Before you talk about diarrhea, let me just say that carcinoid crisis, like in the operating room, is when you drop your blood pressure, basically, and it drops by a lot. And that can happen, usually happens, as Marianne said, when you have a liver, you have liver metastases. But there are certain tumors that are, say, in the ovaries, for example, where the blood does not drain through the liver and get metabolized and broken down. So if it goes through the vena cava, which is the alternate method of drainage from the abdominal cavity, or if it's up in the lung, it bypasses the liver and doesn't get metabolized. So those people can have those same symptoms of carcinoid syndrome. In the operating room, when the patients drop their blood pressures, basically they give vasopressors, things to raise the blood pressure. And like I said earlier, we treat people with an octreotide drip prophylactically, but there's some evidence that maybe that doesn't do much. But Aman, you're going to talk about dumping and diarrhea.
Right. So I agree. When I hear carcinoid crisis, I usually picturize that it's some sort of a operative procedure. A patient has very critical hypotension, bradycardia, and those kind of life-threatening reactions. In a functional neuroendocrine tumor patient, like Marianne said, if you have a bad, that's more like a breakthrough symptom, and you want to, basically you need an extra dose of octreotide so you can use the short-acting. So there's a subtle difference between these, there's no hardcore definition, but crisis is what worries us. The crisis is a very different, profound state. Whereas carcinoid syndrome, diarrhea, or flushing, or other manifestations, you will have those upsurge of the serotonin, some bad days and some good days, etc. So not every worst day is a carcinoid syndrome crisis. I also want to caution you that the diarrhea in carcinoid syndrome patient is not always from carcinoid syndrome. There are other various factors causing diarrhea. To name a few, short gut syndrome. Somebody has a small bowel resection, so short gut syndrome could be one of the reasons. Bacterial overgrowth can be seen in some of our NET patients. Bile acid diarrhea, so somebody who has gallbladder removed as a part of surgery, so the bile leaks into or drips into the small bowel and it irritates the small bowel and kind of gives the diarrhea. So there are so many other factors can give steatorrhea, which is basically fat malabsorption. So there are different types of bowel movements. So not every diarrhea in NET patient is a carcinoid diarrhea. So you have to be careful about that as well. And they are all treated differently. We fortunately have different ways to circumvent some of these things and certain medications or dietary modifications that can change things. And again, one of the E's was emotional stress, right? So don't panic and don't make yours, because the stress would only make these symptoms worse, right? So, know that, okay, you're having some of these symptoms, and then the rescue medication for breakthrough symptom is short-acting octreotide. So always have access to that, especially early on in your diagnostic process when your symptoms are not fully controlled or you're not, fully optimized.
Another quick thing is, isn't it true that you could really tell carcinoid syndrome versus dumping is if you're fasting and you're still having explosive diarrhea? That's what I've always been told, that if I wake up during the night, that's really carcinoid syndrome, not
Dumping? Yes. So the uniqueness about carcinoid diarrhea, it's a secretory diarrhea. So it's a different process there. So it's not just the food, or it's like you could be completely not eaten anything all day, but your gut actually dumps or secretes a lot of intestinal juices, chlorides and all those things, and pulls in the fluid from the body, and then you have all this diarrhea fluid. That's why a carcinoid diarrhea patient, high risk for dehydration, so that, and dumping would be you ate something with high sugar load and high osmotic pressure, and if you have low small bowel or small gut length, you kind of have immediate dumping, or you have urge to kind of defecate. But carcinoid diarrhea can happen regardless whether you're eating or not eating, because the way in carcinoid, the serotonin, the way it works, it causes chloride efflux and it causes secretory diarrhea. So your gut could be completely empty, no food, no nothing, but it pulls in all the electrolytes and water from your vasculature and dumps it into the gut, and then that's why you're at so high risk for dehydration. This happens not only serotonin, but VIPoma patients. They also have a tremendous amount of diarrhea. So you're right, Marianne.
Can I just have a quick question?
Marianne knows a trick or two about, after 20 years.
I have tons of tips that I can tell you on how to help with dumping, how to help with defibrilling. I have all those little tips, so just reach out to me, I'll give you some tips.
Can I add one more comment? Anytime you see a NET specialist, also if you're having nutritional issues, GI issues, diarrhea issues, ask your oncologist, can I talk to your nutritionist? Because we cannot do it all. We only get 1.5 hours to talk to the patient, and we usually focus on the medical management aspect of it. But most of us are equipped with a very well net-focused nutritionist, and we kind of bring them over so that they can give you nutritional guidance and tell you things to avoid, things you can do. And sometimes we even have really good booklets, or Ipsen used to have this really nice nutritional guide. So do seek if they have a nutritionist there, that if they can talk to you after your appointment. And I think they can give you some really interesting and cool points.
Brandon, were you pointing to something back there? All right, so visit that back table on your way.
I just have a quick question. You mentioned epinephrine being a trigger, and we know that, but Don is allergic to bees, so he has an EpiPen. So should we give octreotide automatically when we give the epi? Or, I'm just, how can...
Some people say that the epinephrine thing is overblown.
Okay.
Like in Dr. Palm.
We haven't had to use it since it's been diagnosed, but...
Theoretically, it causes more secretion of serotonin, so you're supposed to, in the operating room, avoid epi and use different vasopressors. But, the key thing is you just got to raise the blood pressure, so people do give epinephrine, and I think it's a little controversial.
Yeah, so in your situation, although it's very tricky, but anaphylaxis is a life-threatening situation, right? So anaphylaxis, you're going to have swelling of your throat, neck, and, so it's literally life and death scenario. So there is no option. You have to use EpiPen. Maybe just be sure, don't be very generous in using it all the time. But if you know that you have an insect bite or bee sting, and then you start having those symptoms, then you'd rather go with Epi and then be safe and go to ER, closest ER.
They're in the same little container. We keep them together. So octreotide and epi.
Wow. Stay away from bees.
Well, all right. I think that we've covered a lot of ground today, you know, and we really appreciate everybody being here. Our thanks to the panel. Okay. And, you know, it's amazing that they stay around all day to answer all these questions and just, so really, really appreciative. You know, we couldn't do this without them. We can rent the room, but we need some experts. So really awesome. Anyway, if you ever need to reach us, you could reach out, netcancerawareness.org. We have the toll-free number, which if you don't know it, we can give you all that, but it's all over the internet. So at this point, I think we're finished.